which is from Dr. Jay Powell, who's an associate professor in the Division of Cardiothoracic Surgery here. Dr. Powell got his MD degree from the University of Chicago, and then he did his general surgery residency at the UCSF East Bay General Surgery Program before he went to Duke University to do his cardiothoracic surgery training. He's been on the faculty at the University of Texas, San Antonio. Then he went to the University of Washington in Seattle before he came here in 2017 to join the cardiothoracic surgery division here. And today he's going to give us an update on the mechanical circulatory support of the heart. Thanks, Dr. Powell.
Thank you very much for the introduction. And thanks for the opportunity to speak about a topic that's near and dear to my heart. This is a field that's very interesting, has a long and storied history that's worthy of maybe a Telemundo special. There's the dominant patriarch, a young upstart, possibly some grand theft, a long-standing feud, and ultimately a resolution. But what's really exciting to me is how rapidly this field is moving. So the cabbage that's going to be done later today is essentially the same as was described by Dr. Sebastian Favallaro in the 60s. What the LVAD will do tomorrow is via a technique that wasn't in regular use even 18 months ago and is different from what we'll do on Wednesday and Thursday. So back in the 80s, this field first came into the popular culture. And these are some pictures from a Life magazine that I have on my desk. This is the first heart pump that was used to bridge a patient to transplantation. And I'll read you the caption there that says, "This patient was supported for almost 3 days prior to his heart transplant, after which he survived for another 36 hours. But it was astonishing enough to make the cover of Life, along with some other questions that have been answered since. In any case, this is a field that's kind of evolved rapidly since that time of these types of total artificial hearts or biventricular support. To put it in context, the problem that we're dealing with is heart failure. And heart failure is one of the largest consumers of healthcare resources today. The black line and the triangles are the projected numbers of new cases, whereas the dotted lines and the squares are the actual numbers. And you see that there's a very different trajectory. But just take a look at some of the numbers. So 670,000 new cases of heart failure in 2007. Now, that's all patients with heart failure, but we're specifically talking about those with advanced heart failure. That's a subset of about 10% of the total population of patients with heart failure that are the sickest. Those are the ones that we talk about with transplant and whatnot. So if you take 10% of that, we're looking at tens of thousands of patients per year that need some kind of advanced therapy. And the treatment, the best treatment that we have is still a heart transplant, but that's been limited by the availability of donors for the past 30 years. And in the U.S., we look at somewhere between 2,000 and 2,200 donor hearts every year. So it's an order of magnitude less than the need for these patients. So that led Lynn Werner Stevenson to comment that treating heart failure with cardiac transplant is analogous to treating poverty with lottery tickets. So even though LVADs and mechanical support had come about in this era, it was still considered to be a field that was a last-ditch effort to those patients who weren't going to survive to transplant. And so part of that was related to the outcomes that were being reported in the 80s and 90s and early 2000s with these devices. So one of the first papers that I presented when I was a cardiac fellow was looking at the use of LVAD bridges to transplant using the Duke MCS database. And this was notable because Duke had a very aggressive transplant and VAD program and would routinely bridge patients to transplant with a VAD, and the outcomes were essentially comparable. So if a patient got bridged with medical therapy versus with a VAD, their post-transplant outcomes were equivalent, which is very different from the larger registries, both STS and Intermax and ISHLT at that time. And so as our experience with these devices grew, the number of patients that were being bridged to transplant with some type of mechanical support grew as well. I should note also that that presentation that I gave in 2009 was moderated by Joe Cleveland. It was the first time Joe and I met, and maybe fortuitous 10 years later. So in any case, as the number of patients with LVADs increases, in many parts of the country, this number of 50% is as high as 80% in the Pacific Northwest or in high population density centers like in New York City. So LVAD therapy is definitely here to stay and has become a very real treatment option for both patients that are eligible for transplants and those that are not. So I'll show you some pictures. So which of these patients had an LVAD? And the answer is all of them, of course. There's the mother in Shiprock, New Mexico, a carpenter, high school student, a professional photographer, a retired infantry commander, a school teacher in Anchorage, the lead designer for the Boeing 777, and this guy who, amongst other things, has turned out to be quite a PR boon for LVAD therapy. You can see here he's disconnecting one of his two power sources for no apparent reason, one of the things that we clearly advocate not doing. So the first device that really brought us into the current era of LVAD therapy was the HeartMate XVE. It's a large, noisy device that worked very well for about 18 months, and then it just seized and crapped out. You can see here on this plain film how big the device is. Sat in a preperitoneal or often intraperitoneal space, and it worked well for these patients, but again, once it failed, and that was the end. But this device was the first one that was compared to medical therapy in the REMASH trial, which is the randomized evaluation of mechanical support for the treatment of congestive heart failure. And these numbers, you'll see 50% survival at 1 year and 23% at 2 years are astoundingly low by modern standards, but they were considerably better than the best medical therapy at the time in the early 2000s. And so this led to the approval of this device, the HeartMate XVE, as a viable therapy for patients ineligible for transplant. There were significant improvements in quality of life questionnaires, but the morbidity and mortality in this group was significant, especially near the end of the device lifespan. As a follow-up to this study, the FDA approved this field of DT therapy or destination therapy. It led to reimbursement for implanting these devices at designated DT centers, and it created INTERMACS, which is the post-approval registry for long-term outcomes, although at that time long-term was simply 18 months. So the younger brother to the HeartMate XVE was the HeartMate 2, and this was in trials when I was a resident, and it was significantly different in the engineering behind this pump. So this is a continuous flow device, which means that unlike the XVE, which pumped blood forward at a set rate and a set stroke volume, this pump pumped continuously with an impeller in the bloodstream. And it was shown to have significantly better short and long-term survival compared to the older devices. And so this device became the essential workhorse for the MCS field for the next 5 to 8 years, and the vast majority of patients worldwide that are currently on support are still on this device. It's proven to be a very durable device, but again, not one without risks. Several years later, there became some awareness of sudden pump thromboses in patients being supported with HeartMate 2s, apparently without any inciting events, and this was found at multiple sites in multiple registry analyses. 3 centers, the Cleveland Clinic, Duke, and Barnes-Jewish, 3 places with significant LVAD experience, noticed that somewhere around March 2001, there was an abrupt increase in the thrombosis rates of patients being supported with the HeartMate 2. And a number of factors were identified with this. There may have been some manufacturing changes. The pump came out of study protocol around that time, and so there's a little bit more variability in implant technique, patient management, patient selection, and so on. But it appears that all of those things played a role and leading to this increase of pump thrombosis, need for pump exchange, stroke, and so on. Since that time, there's been a number of guidelines for the management of these devices, both in terms of surgical technique, anticoagulation, and so on. And the stroke and pump thrombus rate has dropped back down to baseline. Around this time, the first third-generation device came on the market. This is the Heartware HVAD, and the device is small, but this is a really big hand, I think. But this was notable for 2 things. One, it was the first intrapericardial device, which means that you didn't have to create a preperitoneal pocket to implant it. So surgically, it was very appealing to us. But it also had a very different technology in that on the bottom left, you see the HeartMate 2, which is an axial flow device, which means that the impeller is in the blood flow pathway, and it pressurizes the blood by spinning somewhere between 8 and 12,000 RPM. The top left is a hardware HVAD, which is a centrifugal design, which means that blood comes in at 90 degrees to the impeller. The impeller spins, and by centrifugal forces, pressurizes the blood and pumps it out to the periphery. The device worked well, was considered non-inferior to the HeartMate 2, and because of the surgical ease of placing this device, many of us were very enthusiastic about using this. There were some other advantages: decreased right heart failure, decreased bleeding, and so on. But the stroke rate was notable. It was more than twice the rate of the HeartMate 2. And a lot of investigation went into this. And what we realized is that not every pump is the same. Not every continuous flow pump is the same, and we were managing them the same. So if you look at the HQ relationship, which is the flow versus pressure head relationship, every continuous flow pump, whether it's the water pump in your car or an LVAD, has this type of relationship, meaning the pressure head across the inlet and outlet of the pump determines how much flow goes through the pump at any set speed. So these different lines are the different set speeds that you can determine on the pump. And what you see is for any small change in pressure or increase in pressure head, so moving to the right on the x-axis, leads to a pretty significant drop in the pump flow. And if you look at this on a beat-to-beat perspective, what happens is the pressure head is low during systole, so that's the pressure between the LV and the aorta, and relatively high during diastole, so that's the pressure between the aorta and LV during diastole. And so what this leads to is a pulsatile flow. Even though these are considered non-pulsatile or continuous flow devices, there is still beat-to-beat pulsatility on these devices. And when that pressure head increased, meaning the patient became hypertensive or afterload increased, the trough flow during diastole dropped off. And when it drops below 1.5 liters or so, there's areas of stasis in this pump. And that leads to potential platelet aggregation or a little thrombus, which then gets ejected during the next heartbeat, and the flow goes up to 6 liters a minute. And so this presumably is the cause of the higher stroke rate without any identifiable pump thrombus in the HVAD. This led to some changes in patient management, namely afterload reduction. Remember, these patients typically are in pretty advanced heart failure. They've been weaned off all their blood pressure meds and everything else that every other patient with heart disease has, and we never thought to restart it. But with this pump, it's clearly important that a patient that has high afterload or high blood pressures with an HVAD is particularly susceptible to stroke. So as these devices got better, our understanding of how they work and our management of these patients had to improve along with it. So that brings us to the latest and greatest, the HeartMate 3. Dr. Cleveland is one of the national PIs for this study, and this device is a centrifugal pump similar to the HVAD, but has some design elements that are designed to reduce the likelihood of stasis in the pump with resultant pump thrombus or stroke. The features of this pump that I think are notable are the fact that it's completely magnetically levitated, so there's no bearings that generate heat in the pump body. And heat, obviously, in the bloodstream is a major problem, leads to platelet activation, thrombus formation, hemolysis, and so on. So this device is supposed to avoid that, and there's an inherent pulsatility mechanism in the pump that is supposed to provide some washing of these areas that may have stasis. And when compared to a HeartMate 2, so the centrifugal pump, the top line is the HeartMate 3, axial flow pump is the HeartMate 2. You can see that both short and long term, we're out to 2 years at this point. The results are superior with the newer devices. The bottom graph is the stroke rate, which, although there's a blip in the early peri-op phase, in the long-term results, the outcomes are significantly better. There hasn't been a pump with these types of low stroke rates. And for us, a 10% stroke rate is still quite good. And what you see is that it kind of levels out to about 10% between 6 and 12 months and then stays there for the duration of the patient support, which is very appealing. So what this means is that over a relatively short time period, since the time that I was in training, the perioperative mortality of an LVAD implant has gone from exceedingly high to that approaching general cardiac surgery. And there's a number of reasons for that. Early on, as VADs were thought of only as last-ditch efforts, patients were being referred once the writing was on the wall about what their outcome would be. That's changed with time as we've learned to select patients more effectively. Our surgical techniques have improved. And now, like I said, we do these cases with a perioperative risk in the low single digits. So in a relatively short time period since my training, we've gone from this to this. And that has significant impacts both for patient perspective, marketing, of course. Nobody wants this, and everybody thinks this is pretty cool. But for us, it makes a big difference. It's physiologically superior for the patient. For patients that are undergoing transplant, there's a significant advantage to not having a sternotomy in place. One of my former colleagues had made the observation that a heart transplant is the perfect cardiac operation, and an LVAD really messes that up. If you've ever seen one of these operations, it's entirely true. So what we find is that when a patient has had a sternal-sparing LVAD implant, their transplant operation is considerably easier with less blood transfusion requirements, which has a significant impact on allosensitization and the risk of later rejection. So I'm going to transition now to show a couple of projects that we've been working on here in the last year and a half or so. So we've had a couple of residents, both Chris Hawley and Yihan Lin, have presented some data at ISHLT recently using some techniques that are kind of unique to our facility. So Chris Pierce is the manager of our MCS program, and he has developed a technique to look at the electrical parameters of these pumps in a way that isn't done even within the industry. And essentially what happens to these pumps is that the pump has electrical power consumption, and that history is stored within the pump. Traditionally, you send that off to the manufacturer, and they give you back some analysis. But Chris and his colleagues in Arizona had previously designed a mechanism to decode the data and look at it themselves. So I'm going to show some of Yihan's slide from Nice. So this is what you see when you look at a patient with a heart-made HVAD. The screen on the right is the screen on the system controller, and it shows you on the left side the pump flow, the set RPM, the power consumption, instantaneous power consumption. And on the right side shows you some graphical displays of both power consumption and the calculated flow. So that's not very useful other than to tell you, well, they're flowing at an index of 2.1 or 2.6 or whatever it may be. If you send that data to the manufacturer, this is what you get back. You get back a current VAD parameters in the upper right and a graphical history of the past 2 weeks of controller calculated flow, pulsatility, power consumption, and the speed, but not a whole lot more. There may be some notes at the bottom. There's some alarms and whatnot, but this isn't very clinically helpful. What Chris realizes is that if you took this data and looked at it yourself, this is what you got, which again may not be very helpful until you really stared at it for a while. Then you recognize that there's some serial numbers, there's some date stamps, and I should mention that none of these column headings are identified in the log file, so this is something that he figured out on his own and I think is really unique. So there's some information about the hardware, some timestamps, information about the alarm statuses of the pumps, and the instantaneous power settings at 15-second intervals. So suddenly you have a bunch of data on these pumps that isn't readily available. And anytime you have this kind of data, you want to know what to do with it. So if you can graph it yourself, as shown here, you can compare two regions, the blue and the gray, and you can look at all of the pump parameters in a much more granular fashion. You can compare them to look at power pulsatility, which is on the lower left, which is essentially a signature of pump performance, and see if there's any changes to that. So here's an example where this type of data becomes clinically relevant. So this is a patient that was on an HVAD doing quite well, but there was some event that happened here, and at that point there's an increase in power, calculated flow, pulsatility, which kind of resolved, went back up, and then settled at a new baseline. And using this technique, we can analyze these two segments in the two colored regions and say there's some significant change in the pump parameters. The pulsatility is different, the trough flows are different, the variability in the pump has changed. So even though the pump flow is essentially similar or still within a normal range, there's a significant difference in the pump performance here. And this is only available if you look at it in this mechanism. If you simply looked at the monitor, you say, yeah, it's still working just fine. You wouldn't recognize that a thrombus just went through the pump, as is typical with this pattern. We also have the benefit of working with some very thoughtful heart failure cardiologists here, and this is a paper that was written not too long ago about the vascular implications of living with a continuous flow LVAD. And a lot of these things that are on the schematic on the right side, such as epistaxis, changes in aortic diameter, de novo aortic insufficiency, and so on, weren't identified in the early patients with LVAD simply because they didn't live long enough to have these problems. Now that these patients are living 8 to 10 years on some of these devices, these long-term issues are becoming more better understood, and a lot of it's due to our understanding of how the body responds. And I'm going to show some data that Bill Cornwell, one of our colleagues here, has presented before. So this is the impact of changing pump speed on aortic pressure tracings and sympathetic nerve activation. So across the top, you have a pump that's at 8,400 on the left and 10,600 on the right. So 8,400 is a relatively low speed. In the middle row, you see a blow-up of the aortic pressure tracing, and you see a dichrotic notch in the first couple of pump speeds, which suggests that the aortic valve is still opening, that the blood is pumped out through the LVAD and parallel through the aortic valve as well. As you increase the pump speed, more of the blood flow preferentially goes through the VAD. The aortic valve is closed, which is, you can tell that because there's no longer a dichrotic notch. The mean arterial pressure has gone up, and the pump flow has gone up. But interestingly, you see that there's almost a 50% increase of sympathetic nerve activation. And from the medical literature, we know that that's responsible for a whole host of problems that were shown here: hypertension, renal disease, and so on. And they showed that the correlation between pulse pressure, which can be modulated by setting your pump speed higher or lower, can be correlated to the sympathetic nerve activation. So there's lots of ongoing studies regarding autonomic dysfunction in patients with continuous flow LVADs. Obviously, a lot more for us to understand about how these pumps impact the patient's native physiology. The last study I'm going to show is something else that Bill Cornwell is very unique in doing. He uses a Millar catheter which generates these PV loops, which many of us haven't seen since first year in medical school. But he's shown that you can measure RV function by these pressure volume loops at different states of exercise. And one of the projects that we're working on now, and this is something that Jordan Hoffman recently got a grant to study, is how the RV responds to different surgical techniques for LVAD implantation. And although we're relatively early in the process, it's exciting to see how the RV dynamics change when it's faced with increased preload from increasing LVAD flow and so on. So lots of areas for investigation in these fields. And I'll conclude with an invite to any of you that have any interest in this field to talk with us, either me or Joe or any of the cardiologists, because we need lots of new ideas to keep moving this field forward. Thank you. I'd be happy to take any questions.
How many LVADs are being implanted here at the university, but in a year now?
So over the last 5 to 10 years, somewhere between 30 and 50 a year.
And that is how many heart transplants? 10? 15?
We're on pace to do 50 this year.
Jay, that was a great talk. With the emerging evidence or theories about what's causing these long-term complications and with the sympathetic outflow, are there any new treatments proposed? So sympatholytics or parasympathomimetics or something to attenuate some of that GI bleeding and hypertension and muscle wasting. Now, having identified maybe a potential cause, is there a theory about what to do next for treatment?
Sure. So I think we're still in the speculative phase for that. When I was a fellow, if someone had a GI bleed, the treatment was just to turn the pump speed down. And there was some understanding that by decreasing pump speed, you cause less shearing of von Willebrand's factor, and maybe that had something to do with it. But there's clearly some autonomic function as well that needs to be modulated. There's been also increased interest in using heart failure medications for these patients that we didn't used to do 5 to 10 years ago. And that's led to a realization that some of these patients will actually recover their cardiac function in addition to their other medical illnesses. So I think Like I said, there's a lot of room for investigation. Certainly, it makes sense to treat somebody with heart failure for heart failure, which we tended to stop doing when we put an LVAD in them. So I think all of those, managing their autonomic surges, managing blood pressure, managing the rest of it is certainly going to be important as we move forward.
Any other questions? No, well, thanks for two great presentations.
Thank you.